All right. Well, good afternoon, everybody, and welcome to our latest installment of Learn at Lunch series. Again, this month, we're happy to have Dr. Jonathon Geisinger from Orthopedic Institute in Sioux Falls, and today's topic is anterior cervical surgery versus disc replacement. So why don't you go ahead and take it away, Dr. Geisinger?
Sure. Well, thanks for having me again, Jeff. I appreciate it. And if anybody has questions going through, don't be afraid. Just speak up and we can address them as we go along, or you can save them to the end, however you prefer. So this talk I'm going to talk about anterior cervical surgery, and there's basically two options that you have to do. It's either a disc replacement or fusing, and so we'll kind of step through that. Many of you probably were on the last talk I gave, but that's my family here. And real quick history about me is I'm from Spencer, Iowa originally, and then I went to University of Iowa for 8 years and did med school there, and then residency out in Royal Oak, Michigan, just north of Detroit for 5 years, and then spine fellowship up at Twin City Spine for a year, and then came here to Sioux Falls and been doing a lot of spine stuff here, so it's been going really well. And that's my family at the zoo right there. I don't know if you can see it, but that's the brown bear right in the back right there. So really with the anterior cervical surgery, there's a couple options, and this is the outline of kind of how we're going to go through. I'll talk about the surgical approaches first to the cervical spine, how it's done, show you some of the risks, some of the possible complications for doing this exposure to get to the front of the cervical spine. We'll take a look at two different options as mentioned, the disc replacement versus fusing. We'll take a look at both why one's better or why the other one's better, and look at the pros and cons of each one. And then we'll talk about the indication for surgery as well, and really who's a good surgical candidate for each one of these procedures. So real briefly before we get into it, just so you can kind of keep in your mind the type of person that we're looking at who would be a candidate for either one of these, is it's going to be somebody who has myelopathy, cervical myelopathy, like we talked about last time, where they have compression on the cord right at 1 or 2 levels for a disc replacement, versus also people that have like a disc herniation or stenosis in that foramen where that nerve exits and is causing pain that goes down the arm. So in general, these are the kind of people we're looking at for this surgery. The surgery itself, kind of getting into the approach here, it's done from the front of the neck, and you can see here this is the incision, and you can do it on the left side or the right side, and it's about a 1-inch incision if you're going to do one level, and it's a little bit bigger if you're going to do multiple levels. You can get to about, through this one incision, you can get up 2 levels and down 2 levels. So if you had to, you could do 4 levels just from that incision. But really, if you put your incision up a little higher, a little lower, you can actually gain access all the way from C2 down to T1. So it's a very powerful exposure. These are some animations that I kind of put together and put these marks in, and I'm going to go through each layer, and I'll show you how we dissect down to get to the front of the spine. And so this is about where your incision would go. Typically, I go in on the left side, as most orthopedic surgeons do. Neurosurgery, they tend to go on the right side for reasons, if you're interested, I could explain. But so for the most part, we go on the left side. And that incision, I have another mark that just takes the skin off. And this is the platysma muscle that comes down, this big sheet of muscle. It's usually just very paper thin. Sometimes people don't even hardly have one. But you incise it a little bit right here and dissect down through the fascia and some of the fat tissue right there to expose the muscle underneath, which is the sternocleidomastoid muscle. And now this zooms in and shows you the muscle right here, and these are the strap muscles. And so you don't cut these muscles, but you just gently dissect around them, and you find a plane, and you kind of weave and wind your way down through here. Really the only muscle you cut is that platysma. And then coming down, this takes another layer of muscle off. This is the trachea right here. And the trachea, you move over more medial. And then these are some of the other small muscles, and those are going to go a little bit more lateral, some of those strap muscles. Now that the windpipe is gone, the trachea is gone, this shows you where the esophagus is. And typically it hangs on pretty tight to the trachea. So as you push the trachea over, the esophagus follows, but you have to be very careful to dissect down around it. And it's a fairly, you'd be surprised how flimsy some of the walls of it, and you have to be careful to stay out of it and stay in a good clear surgical plane and move that over medial so you're not causing a hole in the esophagus. And then these are the other muscles on the side that you continue to dissect down around. And now this takes the esophagus off, and you can see now as you follow the exposure down, you're right on top of the anterior part of the front part of the cervical spine. And this is about C6 right here and C7, and that's the disc space. And so now, this takes all the muscle off, and you can see right where you're looking at when you come down on the anterior part of the spine, the disc space and the vertebra, and you can see the arteries, the vertebral arteries over on the side, and then the nerves are obviously coming out from the side as well. Taking a little closer look now, you can see I removed the disc in this animation. So now as you look straight back, you're able to see the spinal cord, and this is the spinal cord right here with the disc completely gone. And you'll notice that the vertebra of the cervical spine has this lip that goes up on each side. That's called the uncinate process. I'll show you that a little bit more in detail in a second here. This simply zooms in. So really when you come down on that front of the spine and you dock, this is exactly what you're looking for. You put a pin here and a pin here, and you can gently distract this, and that'll help open up this space so you can see right into the back, and you can dissect all the way down to the spinal cord right there. This really shows you well the uncinate process. This is a disc is still in here. The disc is here. And here, this is actually a joint, and this connects. You can see one level up right here. You can see where that's actually a joint. And there's synovial tissue in there, just like your hip or your knee has. And anytime you have a synovial joint like that, it's prone to arthritic changes, and you get osteophytes and bone spurs and these kind of things. And they grow back and they pinch and they push on the nerve right here. You also can have disc herniations where this gelatinous material from the nucleus pulposus goes through the annulus and can push out, and it can pinch on the nerve, it can pinch on the spinal cord, can pinch anywhere. But that's typically with younger people. Older people typically have the tightness of the foramen where the nerve comes out due to more of the osteophytes and degenerative stuff. And again, that's where those form right here as it pushes back. So this is kind of an overview of from the top looking down in this section right here. And it shows you how you come down that plane just like I talked about, and you eventually get down to the spine and you expose that. And then you push everything over here medial, the windpipe, the esophagus, and you push the carotid artery and the vertebral artery. All that stuff stays lateral. And then you can gently retract and almost come down straight on top of this the vertebra right here. So as you can imagine, there's a lot of precious stuff in the neck that goes up to the head. So there's a lot of risks when you're doing this if it's not done correctly. There's things like the recurrent laryngeal nerve, which is this small little nerve. That goes to your voice box. There's a superior laryngeal nerve that goes to the voice box. If you, like the esophagus, there's issues like I mentioned. If you get into that, you could have swallowing issues. Even dissecting it over, if you're doing an extensive approach, it can give people swallowing issues for a period of time. Obviously, you need to stay out of the carotid artery for obvious reasons, and also the vertebral artery is another vessel that can be at risk if not done properly. So basically, after you do this, yep.
Is there any fascial connection or any connective tissue at all between the esophagus and the anterior cervical spinal column?
The esophagus and the anterior, no, not really. There's some prevertebral fascia. Sometimes people can get some scar tissue and stuff like that just with age, and it kind of can scar together. But for the most part, the prevertebral fascia is just, it's kind of like a cobwebby type substance, and you can come down on it and you can just take a Kittner, which is a little cottonoid kind of thing on a forceps, and I just bluntly dissect through that, and for the most part you can just gently tease that. It's a very, very wispy thin fascia. If it's a revision surgery, it can scar in harder, and that's when you can lead to some more swallowing type issues because you have to be a little bit more forceful in dissecting it out. But for a first time going down, it's usually not too bad. And then there's something called the prevertebral fascia that doesn't typically attach to the esophagus, but it's a strong connective layer right on the front. And you have to be a little bit more aggressive to incise that to actually get to the bone. But there's really no problems after you able to dissect that down.
So you really don't see a lot of trouble typically with post-surgical adhesions creating, you know,
No, I can get into that a little bit later. But in terms of the adhesions, no. Typically, there's so much mobility in the neck. You can even take your windpipe and you can push it back and forth, and you can see how much mobility you have. Typically, no. Sometimes the prominence of the plate, like I'll get into later for a cervical fusion, if you're doing multi-levels, sometimes that can give people some dysphagia or some issues swallowing.
thank you.
So the next thing you do, and this is all the same for disc replacement and fusion, is you're coming down. This is called a kerrison, and you're able to expose. You take that whole disc out, and then you can get back with these instruments right to that back little corner, which I kind of blow up here. And so the kerrison comes in, and you can clean out all of this arthritis and bone spurs and take that pressure off of the nerve. And so that's really the important part of the procedure is getting back and trying to clean that area out to hopefully give them a good decompression and give the people relief of their symptoms. Once again, just kind of an overview. So now we can get in. Now that you understand kind of how we do the approach and how I get down, the next thing is to look at doing the fusion versus the disc replacement. And so just to give you kind of an overview of what a cervical fusion is in terms of going from the front, is you go down, you take that disc space out, and then you put a spacer in there. And the spacer can be made of many different things. Bone is the one that I use, and this is an allograft, so it comes from another human, typically the pelvic crest, in which you have a cortical bone and cancellous bone in the middle. I really like this because it gives a good structure for bone to grow through and fuse. And it just looks great after with x-rays. If you have to do imaging or anything, there's no artifact, and it really works great. There's another option called PEEK, which is basically man-made material, and some of them put metal on the top and bottoms, but basically it's an artificial plastic type material that can be put in, and then in the center of it you put bone graft and things like that, and the idea is it grows down through that to create a fusion. Another option is titanium. And bone grows very well into titanium, and so some people use titanium cages. And then after you put that inner body, that cage in there, then you typically put a plate over the front. And this would be an example of a plate that goes on, and you put 4 screws in, 2 screws into each vertebra, and then there's a locking mechanism that prevents those screws from backing out. So basically that is an ACDF. And you can do anywhere from 1 up to 6 levels all in one time with this. And it is an extraordinarily powerful surgery that you can do. The cervical disc replacement, which is what these are all different examples of. This top left one is called the Mobi C. And I think it's probably the best disc replacement out there. And so what it is, and I'll get into it a little bit more, is it's a metal top, a metal bottom, and then it has a plastic bearing surface in here that slides back and forth. And that's basically the stuff you see spray tanks made out of. It's the same material, but this is just a much more dense type of material that they make in these. Another option down here, this is a metal on metal articulating device. This is the Prestige by Medtronic, and that's a metal on metal bearing. So you have 2 metal surfaces rubbing against each other. The third one over here is also by Medtronic, and this is called the Bryant disc, which they recently stopped making due to low demand, but overall it was a good design. It had metal on the top, metal on the bottom. It has a polyethylene bearing surface, just like the Mobi C had, and then it also had a sheath that went around. So if you had wear particles, the idea was the sheath would keep those wear particles within the disc instead of allowing those to go throughout the surgical area in your body. So a little bit more detail about the Mobi C, which when I do disc replacements, this is the one that I use. So the Mobi C has the metal, it's a cobalt chrome on the bottom and also on the top. It has a titanium plasma spray, which helps bone incorporation, and also this hydroxyapatite coating, which is this white stuff up here. And basically, there's just a lot of research has shown that this really helps bone grow into it and incorporate, so you get a not only a quicker but a better ingrowth to the device, which is very, very important for disc replacement. And then it has the polyethylene insert. And the idea here is as it moves back and forth, that top part can toggle up and down, and it basically sandwiches this piece of plastic in the middle, and it can push the plastic this way. And if you go the other way, likewise, it pushes the plastic that way. So I don't know, it might be kind of conceptually hard to understand unless you're holding it, but basically this piece of plastic here goes back and forth, and it's stopped by this metal piece. And so as it slides one way or another, it basically hits here, and it prevents that plastic piece from being pushed out from the actual disc space. But really, that's the only thing that retains it is just this metal post right here. And yeah, and you have two other plates on the top and bottom, but they're really not connected in any other way to this mobile bearing, basically. This is an image where you can do not only one levels, but you can do two levels. So anterior cervical fusion, discectomy and fusion, you can say it decompression or fusion or discectomy and fusion. Both ways are correct. It was started back in the 1950s, and really the goal with this is you try to get it to fuse. And each level that you do, we typically think about losing about 10 degrees of motion. And as of now, the ACDF is the standard of care. You can use it to treat instability, so if one vertebra is slipping over the other. You can use it to treat radiculopathy, where pain's going down the arm and you need to decompress the foramen and get pressure off the nerve. You can use it for myelopathy if there's central tightness. Deformity is another indication for this. And also if you have to do more than two levels, ACDF is also the way to go. And really, if you're having any problems with a disc replacement, or if you have to do a revision surgery for a disc replacement, this is the backup option. This is the salvage option for disc replacement. Cervical disc replacements, they were introduced back in 1966, and it started as just a steel ball bearing in the lumbar spine. And they thought, well, let's do this in the cervical spine as well. And I couldn't find a picture of that. But as you can imagine, if you put a steel bearing in the cervical spine and moved it around, it was just at extraordinarily high complication rates and neurologic issues, and so it was quickly abandoned. And really at the time, this is 16 years into doing ACDFs at this point, they were doing so well that basically the idea of trying to do a disc replacement was abandoned until 2002 is when there got to be a little bit more kind of interest in preserving the motion. And so there were some new designs that came out about 2002. And so the disc replacement can be used to treat radiculopathy. It can be used to treat myelopathy. You can do either one or two levels. And the important thing, as I mentioned, you really need the end plates to grow into that disc replacement, but you're not having the goal is not to have that level fused together. So looking at some of the cons of doing an anterior cervical discectomy and fusion is really the big concept is this adjacent segment degeneration, and I'm going to go into that in detail in a little bit here. But the idea is if you fuse one segment, that could lead to increased force on the next segment, and which would subsequently lead to the next segment wearing out faster, okay? Not necessarily that it needs to be operated on again, but that it could wear out faster than if you didn't operate on it before. The other issue is the prominence with the plate. Typically with one level, that's virtually never an issue, but if you're doing 4 levels or 5 levels and you get real high in the cervical spine, some people can have some swallowing issues secondary to the plate, like we kind of mentioned before. Subsidence of the graft, that just means the graft sinks into the vertebral body. There's always a risk, this is probably the biggest risk, that it doesn't fuse together. And this is a little on the high side, but if you did a 1 level, there's sometimes up to a 3% chance that they don't fuse. And if you did 2 levels, it could be up to a 6% chance that one of those levels don't fuse. So not fusing is kind of one of the big downsides to doing a ACDF. Looking at disc replacements, there's also some downsides to doing disc replacements. So basically, a lot of the studies, they kind of talk about there's actually pretty similar adjacent segment degeneration, and I'll go into that You worry about subsidence of the prosthesis. Again, just like the ACDF, you worry about the inner body sinking into the bone. You also worry about that disc sinking into the bone. There's an issue with polyethylene wear, that plastic spacer. You worry about that. The metal wear of two metal surfaces on each other, that could also be a concern. We've really only been doing it for probably about 10, 15 years now, of where people have really started to latch onto it and do more of them. So it's a relatively short follow-up as compared to the ACDF that's been going on since the 50s. And the end plates you absolutely need those to heal into the bone so they don't move. This is an x-ray over here where unfortunately it did not heal into the bone. And you can see this is the end of the vertebra. It might be kind of hard to see, but this plate has actually slid backwards into the spinal canal. And so that would be an instance where it didn't heal together. There's also limited sizes with the disc replacement. And if you're unable to get a disc that fits, then you would have to convert over to doing an ACDF. And then these are much more difficult to revise, because if they do grow in, then it's very difficult to get them out. And then also something that's not really talked about, but it's a concern that I have, is trauma. So I mean, it's an articulating plastic spacer in there, and if you were in an accident or a football player, you kind of wonder how that's going to hold up. Versus when we talk about a ACDF, after that fuses together, it's stronger than the levels on each side of it. So really, trauma isn't a concern as much for ACDFs. So I'll go through now and I'll show you some examples of some disc replacements that have not gone well. This is basically that Bryant disc replacement. And this, very unfortunately, is an orthopedic surgeon who had a disc replacement done out on the East Coast. And one way or another, I came across these. And his disc is actually pushed halfway out. So this should be all the way back in. But unfortunately, the way it was put in, it migrated forward and it didn't get good incorporation. And so now it's pushing on his esophagus and his airway and things like that. So that needs to be revised with an ACDF then. This is an image where it shows you multiple different ways that a disc can have issues. So one of the big concerns is heterotopic ossification, which is just continued bone spurs or growing of those spurs. So when you fuse something together, the motion is eliminated. When you eliminate the motion, you don't get formation of bone spurs and things like that in this ossification. But if you still have movement, there's the chance for these bone spurs to continue to develop and continue to form. And that's an example here. And as you can imagine, that's probably pushing on the spinal cord now. This is an x-ray where it shows the disc migrated back. Once again, did not have good incorporation. This just shows you it wasn't put in parallel, and so it's difficult getting it, maybe some subsidence into the bone. This is another one where this is a Mobi-C, and I put the Mobi-C picture over here once again so you can see when the neck is flexed forward, this poly insert right here, you got to imagine that's going to be pushed all the way to the back. And so basically what's keeping this poly insert from going into the spinal cord is this metal post right here is hitting this poly piece. And that's all you got that's keeping that from going back into your spinal cord. So you worry about the wear and something like that, and hopefully it holds up, right? Some of these other images, this one, again, you can see where this end plate has sunk down into the vertebral body, and obviously would need to be revised. This is one where it did not incorporate. In fact, you see some lucency around the implant, meaning there must be some motion there. So I'll give you a little brief history on polyethylene wear. This is a total hip. We've been doing total hips for a long time, and that's where we really started using this polyethylene. This, it's kind of like I said, it's like the consistency of spray tanks, those big white spray tanks you see out in the field and stuff like that, the water tanks. But this is just extraordinarily more dense. So it's very, very good stuff, but it still can wear out as well. So hip replacements have this metal shell right here and a metal ball, and then they have this polyethylene bearing surface in here that it articulates with. And so this is after they wear out in some people. Again, this is the acetabular shell, and this is the polyethylene insert. You can see where that femoral head has just wore through that polyethylene insert. And then the head, you can see it migrates up and it's asymmetric. But more importantly, you see all this, what we call osteolysis, which is where the bone, it's a reactive process of your macrophages. So your white blood cells come in, they try to eat and they try to get rid of this plastic stuff, but they can't get rid of it because they can't break it down. So they make a huge inflammatory response. And all that does is lead to the degradation of your bone right here. And then looking over here, this is how you revise that. So you can go back in and you can put a big cage in there and you can put a bunch of screws and graft bone, and that's phenomenal and it works really well. But your pelvis is different than your spine, and you've got a lot more bone to work with in your pelvis. So one of my concerns is, if poly wears out here, poly can also wear out, I would think, here in the cervical spine, and it's the same poly that we use right here. So that's where Medtronic made this one, who, like I mentioned, is the Bryant, and they're actually not making anymore because there's lack of demand for it. But the Bryant disc had this sheath that it would go around that poly insert, which this is the poly insert. And the idea was if you did have poly breakdown and poly wear from the plates sliding on it, then that would be contained, and hopefully you wouldn't have that osteolysis or that loss of bone from that inflammatory response. But as it is with the Mobi C, you have just the poly that moves and articulates on the metal. The next thing is metal on metal. So same thing with the hip joint. There's hips out there that have a metal head and it articulates on a metal surface instead of being a plastic surface, which shows great wear rates, but unfortunately, it can give off these metal ions, and these metal ions can cause a T-cell response, and that T-cell response can cause things called pseudotumors, which aren't real tumors, they're fake tumors, but it's a big inflammatory mass. And this is a MRI, an example of a big inflammatory mass, all due to this metal on metal hip replacement. And so this is kind of the necrotic tissue in here, and that's what it looks like when you get into surgery. And this can just be extraordinarily devastating to tissue if you unfortunately get one. And so then the other cervical disc option is this metal on metal one. And you can see it's very similar to the hip where you have metal on metal with metal on metal right there. So, I'll just say this now. So this is actually my reason I don't use the Prestige is for a metal on metal hip is contraindicated in a woman of childbearing age because we know that metal ions, no matter what hip you do in terms of metal on metal, it's going to cause an increased ion concentration in your blood and in your body. And so there's the concern that those ions would cross the placental barrier and could be an issue. And we don't know what that issue is, but nobody wants to harm a baby. So we just gravitate towards the side of safety, and you would say, no, you would not want to do a metal on metal hip replacement in somebody of childbearing age. And so that's my idea with the disc replacement. And that's why I wouldn't do a metal on metal for me personally. Is I wouldn't want that increased metal ion concentration. And I'm actually not sure if it's really been studied or looked at, but theoretically, for me, it makes sense. And so that's why I kind of stray away from that metal on metal one. So that's kind of some of the pitfalls there. And we're going to go into now kind of a discussion on adjacent segment degeneration and lever arm and force, because this is really the whole driving force of why we're looking at doing disc replacements instead of doing fusions. So when you fuse these two levels together, you can see that this just simply creates a bigger lever arm. And when you have a bigger lever arm, that translates to more force on the disc space right here, is it's been shown in cadaveric models and things like that. And biomechanical studies is how we've learned that. And so the idea with the disc replacement is that mimics your natural motion, and so that should lead to less force, less moment arms on these disc spaces, which should allow them not to degenerate at such a fast rate. And so you have to unfortunately understand a few definitions to kind of get through this. And one of them is adjacent segment degeneration, which is basically where you have X-ray changes of an observed level that was previously operated on and that segment, but it does not correlate to symptoms. So what that means is if you have this adjacent segment degeneration, you take an x-ray, and I see on the x-ray you have arthritic changes at the next level. Maybe it's an osteophyte, maybe your disc space is a little narrow, but these are asymptomatic people, meaning they have no symptoms. So it really doesn't matter because they don't have any symptoms. The next thing is the adjacent segment disease. And this is when you have adjacent segment symptoms, meaning that somebody goes on to have pain that goes down their arm or stenosis on their spinal cord and they have myelopathy. This is the thing that matters. Adjacent segment disease is what would require you to go back in and do another operation. And so you also need to understand the natural history versus accelerated degeneration. And there's really still no study that shows when you go in and do a one-level fusion or something along those lines, it's kind of a chicken or the egg thing. Did you have to go in and operate on that person's spine because they just genetically were more predisposed to degeneration of their disc space? Or, and does that, or I mean, when that subsequently leads to the next level wearing out, was that just because A, they already had a degenerative process, that's their genetics, or did we cause that next level to degenerate because we went in and fused it and increased the lever arm? So that's a little confusing, and I hope I explained it. And if you guys have questions about it, hopefully I could address it better. But basically, it's a chicken or the egg. Do people just naturally, the ones that are going to get spine surgery, do they just naturally have a genetic tendency to have more levels that wear out versus people that never have spine surgery? So you can see where that would be very hard to study. And really, you look at the natural history side of it, and there's lots of these studies that show, like young people, if you bring them off the streets, less than 30 years old, and you get an MRI, 20% of them are going to have something on that MRI, even though they have no symptoms. Versus when you get to be 60 years old, you can bring in 86% of people will have these abnormal changes, even though they'll have absolutely no symptoms. So it kind of lends to the thought of it's hard to correlate exactly what's degenerative or what's a disease process. And so with the cervical disc replacement versus the ACDF, the idea is with the disc replacement, you're preserving that motion, so you're going to have less force on that adjacent segment. And if you have less force on that segment, it's going to hopefully equate to less problems at the adjacent segment. Versus with fusion, the argument is bigger lever arm, more forces, more likely to wear out the next level. But the studies haven't shown there to be any significant difference between the two in terms of this adjacent segment disease, which is the people that need a subsequent operation. So this is an article, and we'll go through the literature here real quick. And this is an article from the Journal of the American Academy of Orthopedic Surgeons, and this is our official journal that comes from our academy. And so this looked at is a review article that looked at disc replacements versus doing anterior cervical fusions. And so I'll just read, first of all, this box. I'll just read it to you so you hopefully can see it as well. But the authors of these studies, as well as the others, have found equivalent clinical outcomes in pain relief and improved neurologic symptoms following both fusions and disc replacements. However, none of these trials to date suggest that a decreased rate of symptomatic adjacent segment disease, and that's people that go on to have another surgery or are symptomatic, basically, those results when they're compared to arthroplasty instead of fusion basically have not shown any difference between the two. And then furthermore, a meta-analysis that looked at these that was done by Bartels, he concluded that because of the lack of proven clinical benefit for cervical disc replacements, that the use of the devices are not warranted in daily clinical practice. So basically they're saying that the studies have shown that there's some adjacent segment degeneration, but people are asymptomatic. So there's really no point, and they don't end up doing another operation. So there's really not a big discrepancy between these two procedures. And the other box there is, it says cervical spondylosis is a common degenerative condition in adults, and ACDF has had a long history of clinical success in relieving the pain and improving the neurologic symptoms associated with this pathology. Adjacent segment degeneration and subsequent symptomatic disease have been identified as an ongoing clinical concern following fusion, but to date, however, there has not been any clear evidence that fusion increases the adjacent segment degeneration or symptomatic disease requiring additional surgery. And so basically this is from our academy, and they're saying that after you review the literature and look at it, there's no real concrete evidence to say that doing the disc replacement leads to any changes versus doing the fusion.
Doc?
Yeah.
Do these CDRs, do they allow motion in all three planes of movement? And if so, what percentage compared with what would be expected to be normal anatomical range?
So about 10 degrees. So that's the goal, is they try to do 10 degrees. So the Mobi-C can do flexion extension. It can do lateral as well. So they actually say it moves in 3 planes. And then it'll allow a little rotation as well. So that's why they try to draw these diagrams out of 10 degrees. Basically, we think of the top 3 levels. That gives you 50% of your cervical spine range of motion, and then 10% comes from each level below. So at each one of these subaxial levels is about 10 degrees, give or take, you know. And so that's what they're trying to recreate, is that 10 degrees flexion extension.
Thank you.
You bet. And so this is a paper I came across in fellowship, and we have these journal clubs, and we sit down and we analyze things. And I trained under some very prestigious people, and some of them are just gung-ho on disc replacements, and some of them are absolutely not, you know, so it's definitely a controversy. And the one guy who was, you know, kind of turning into an advocate and saying, you know, it looks like a good thing to do, he looked at this and was saying it was a really good paper, and I want to go through it with you, and I just want to show you kind of the problems that I've had with disc replacement. And then after we thoroughly reviewed it, it kind of changed his mind. So this is a randomized trial, and it's from Spine. Now, Spine it's probably the foremost subspecialty spine journal that we have in the country and basically in the world. Like this is kind of the journal to read basically for spine, okay? And this is a randomized trial, and it's a prospective randomized controlled trial. It was part of the FDA approval to get these things pushed through the FDA. So this is like a very legitimate trial, right? It's level 1 evidence, and there's 5 levels of evidence. 1 being the absolute Cadillac, that's the best. 5 being the worst, that's your opinion. Doesn't really matter for anything. So this is level 1. So this is a highly regarded paper, right? So I just want to read through the methods here with you. As part of an FDA IDE trial, single center controlled prospective outcome, they looked at 47 patients that were randomized to getting an ACDF versus an arthroplasty. So they had these people, and they either got a disc replacement or fusion. And their results here is that the success of both surgical interventions remained high at 10 years. Both the arthrodesis and the arthroplasty demonstrated statistical significant improvements in the neck disability index and the visual analog scale neck and arm pain scores in all intervals, including 7 and 10 years. So what they're saying is both of these procedures did equally as well at 7 and 10 years out, being that people got better. But actually, I should rephrase that. They're saying the arthroplasty group did just a little bit better. But they're saying people got better in both groups. They're saying the arthroplasty demonstrated an advantage in comparison to the arthrodesis as measured by a final 10-year NDI. So they're saying that people did better with the disc replacement, and they're saying that was statistically significant judged by their p-value here. And then the patients requiring reoperation were higher in the number in the arthrodesis cohort, being 32% as compared to the arthroplasty group, 9%. So what they're saying is if you got an ACDF, you had a 32% chance of getting another surgery in 10 years versus only a 9% chance of getting another surgery in 10 years. So that's pretty significant. When you look at that and you say, wow, this is the level 1 paper and they found that, that's really earth-shaking to me to see that big of a difference. But that's not significant. So meaning that the finding, it could just be an error in numbers. It's just by chance that they found this because their p-value is too high. So it's not statistically significant, okay? But still, when you see that number, you're kind of like, wow, that's kind of striking, right? And so then they conclude at 7 and 10 years, cervical arthroplasty compares favorably with ACDF as defined by standard outcome scores in highly selective patient groups. And so what they have to conclude, though, is that both groups do well. So so this is the level 1 paper, right? And it's super, and you look at that and you think, wow, this is quite an outcome. But then you read the small print down here, and then you discover, well, Medtronic is the disc that was studied here, and they also funded this study. And furthermore, which I was real disappointed, the article here said there's no relevant financial activities outside this submitted work. And that's not true, because this Mr. Rick Sasso is a guy who gets extraordinarily high. Like, I'm talking to the figures and royalties for this disc replacement that was the Bryant, which is what was studied in this paper. So they're not telling you that, and the senior author is actually the person who designed the thing that he's studying. And so that kind of brings suspect into it. Well, shoot, right? The other thing on page 2, when you look at their patients, they started with 62 people. 15 of them had to be eliminated from the study. 5 they couldn't follow up. They just couldn't find it. But 10 of them, Medtronic just said, the person who paid for the paper said, yeah, we don't want those 10 people in the study. And I couldn't believe that. Every credible paper has, when they kick somebody out of a study, they have a line and they explain why. But that's never explained in this paper, why these 10 people. It's just Medtronic, who also wants the disc replacement to go forward, just decided, we don't like the results of those, or for some reason they just kicked them out. So that's why I was still kind of discouraged. It's got to be a level 1 paper held in such high regard, when obviously the author has a conflict of interest, and they're kicking out 10 out of their 62 people, which is a very significant number to be not including in your study, which is obviously going to change your numbers when you have such a small group. So basically, you have to remember, when it comes to these disc replacements, the industry is making way more money off a disc replacement than they are in ACDF. And ACDF's been around since 1950. The disc replacement's been around since 2002 now. So it's just like generic drugs and brand name drugs. The brand new drugs are going to get paid for a lot higher versus the things that have been around a long time. So, and to be honest, if you just go to Google and you Google search disc replacement versus ACDF, you're going to see all these beautiful illustrations for disc replacements and this just extraordinary marketing campaign that they've put behind them. And, companies do marketing campaigns because they're going to make money off of it. And so they're not dumb. So I think you got to kind of tease out there. I think there are some great things with disc replacement, but you got to really focus on doing it for the right reasons. And so this is our indication for who gets the disc replacements, and we're talking typically it's going to be a young skeletally mature person, so they're done growing. They're going to have cervical radiculopathy or cervical myelopathy, and then people you would not want to do it on would be people that have neck pain. Another contraindication would be instability. So if the level is moving or slipping too much, you would not want to do a disc replacement. Again, pregnant people, you typically don't want to do a disc replacement on. And I also talked about the metal on metal thing already, and possibly some ions crossing the placenta. So I would actually extend that to people of childbearing age. I would not want to do a metal on metal. Osteoporosis, because the graft can sink into the bone. If they've had a previous fusion, you wouldn't want to do a disc replacement around that. And also if they have a bone disease such as DISH or ankylosing spondylitis, or if they have a deformity, there's no role for disc replacements in deformity. And then if you're doing the surgery for a trauma or a fracture, a disc replacement is not a good option. Who's a candidate for ACDF? So basically all these people are. Trump is, Pence is, Nancy Pelosi, Cortez, Ivanka, everybody can get disc replace or get ACDF. So all ages. It can treat radiculopathy, myelopathy. You can treat instability with it. You can treat deformity. Also, if people have associated neck pain, this is the procedure to do. And then I also think about people that are at a high impact or high risk for high impact, like football players. You would want something that was strong and proven in there versus a disc replacement when you don't know how it's going to stand up to trauma. So basically, kind of wrapping up, the ACDF and the disc replacement, they both treat radiculopathy and myelopathy. The disc replacement has strict indications. The ACDF is still the standard of care. It can treat a lot of things. It's the salvage procedure for failed discs. and it has a very proven history. And again, the industry, they're heavily sponsoring the disc replacements. I think they're making a lot more money off them. And you got to be cognizant that they're the people out there funding the studies. They're paying consultants. They're doing a lot of advertising for them. So I think you should be cognizant of that. And I think there is a role for disc replacements, but you really need to be open with the patient and explain to them both options and kind of let them understand, especially if it's that young person. You can kind of give them the pros and cons of each one and kind of help them make an educated decision on which way they'd like to go. So with that, again, that's my number from my executive assistant. If you guys have anybody you want me to see or get them in quicker, you can give her a call. And I'm sure a lot of you already have my cell phone number. And if you don't, I can give that to you. And then after that, I'm open to questions now. Otherwise, I have the 6 questions at the end.
I got a question.
Sure.
The 32 and 9% on the study, did that include both second surgeries on adjacent segments as well as original surgical site?
This one?
Yeah.
I'm sorry, repeat the question one more time for me.
Those percentages include second surgeries that were done at adjacent segments as well as the original site?
Oh, yeah, no, this would just be adjacent segment. I think it just looked at adjacent segment. It didn't look at arthroplasties having to be revised.
No failure. There's really no studies that indicate direct failure.
It's very low. There are studies. Well, I mean, there's the 10-year and 15-year studies, and they've looked at that, but it's very low for them to actually fail.
Okay, thanks.
Anybody else have questions for Dr. Geisinger?
Yeah, this is John Carr, Jonathan. A few questions here. We always ask this question: after you do a fusion, how soon do you feel it's safe to go in there and do manual manipulation?
Of the cervical spine?
Yep, of the cervical spine.
So when it came to a disc replacement, I would be real hesitant because I just don't know how those things would act. But I would say typically at 6 months, when at 3 months, you'd like to think that the whole thing is fused together and bone has grown across. But I think 6 months to be on the safe side to make sure that it is actually fused together.
So you're saying a disc replacement, you wouldn't do manual manipulation even to other segments?
So I would be hesitant. I just don't know how the disc replacement would hold up to it.
Yeah, I agree. That's a concern I have because many people have other areas of complaint, whether it's muscular or facet in other regions. So I wondered what that would have to do with it. So modalities into that region with a disc replacement would definitely be contraindicated as well, correct?
In my mind, I guess that's a great question. I haven't really thought about it too much, and I certainly haven't read about it. And I've read a lot of papers on it, but in my mind, yeah, with trauma or something or moving or I think with manipulations, the idea is to hyperextend the joint. Is that correct? Or
It depends on the technique you're utilizing.
I would say you would not want to stress that disc replacement past the point of where it was intended to move.
So on any of these, when we have people in and they need an MRI, is the fusion metal that you're using capable of having an MRI, or is it something that we cannot perform MRIs on those regions?
All of these things are MRI compatible. The reason I like the allograft, to be honest with you, the best is it's also the cheapest and it's been used the longest by all of them. I like using the allograft because that's bone. And so the plate in front doesn't matter. It's usually far enough away. You don't get too much artifact on the MRI. But inside these, like this plastic one, is a tantalum marker. And these tantalum markers just cause terrible artifact on the MRIs to the point where you sometimes can't even visualize it well. And so that's, again, why I like the allograft. There's no markers. It's just like regular bone, so MRIs work the exact same. And so that's a great reason I use that. When it comes to the disc replacement, this is cobalt chrome, and you cannot see behind these things. On MRIs, CTs, it's extraordinarily difficult. What you end up having to get is it's basically just a fluoro shot with a myelogram done, and sometimes that will allow you to see behind it. And that's a big case too when these get put in just too far back and people aren't getting better. It comes into the question of, well, how do I even properly image it to see if it was pushed too far back to be pushing on the cord, because imaging is so hard from the artifact. But in terms of compatibility, yeah, technically they can all go through an MRI machine.
My last question is, our profession is getting bombarded by the laser surgery surgeons. What's your take on the laser surgery facilities that are in the United States?
Yeah, so we, I'll just say at Twin City Spine, we treated a lot of people that were treated at these laser institutes, and they're typically places that don't follow up. If they have a complication, they don't follow along with it. They send you back to a local guy to deal with. They don't do fusion, so if they over decompress, they really can't fix it from there. There's just been a lot of ethical issues, I think, that was presented along with that.
Okay, thank you very much. Thanks for your presentation.
Yeah, no, thanks for having me.
Other questions for Dr. Geisinger?
Yeah, I got one. Doc?
Yep.
There? How common, or what is the incidence of C3 disc procedure being required?
C3-4?
Yeah.
So a lot less than C5-6. C5-6 and C6-7 are our two highest. C3-4, typically it's lower. I just did one the other day though. Offhand, I would say it's probably about 20 to 25% of the discs that we see. If C5-6 is probably 50 to 60% of the discs.
Okay. Wow. It's higher than I thought it would be. Thank you.
I have a question about, you talk about how you clean out the uncovertebral joint and all of that. When you go in there and clean that out, does it kind of initiate an increased process of more degeneration? Is there a time frame between that? And is that, when they do the laser thing, is that what they're doing a lot, is cleaning the uncovertebral and the foramina region?
So when it comes to laser surgery, I don't think they can do that from the front. They have to do it from the back. And to get to this joint, you can't get to this joint from the back. So their idea is they're just trying to on-roof it from the back side. But no, they're not stopping the motion or anything like that. And in fact, so basically when it comes to the laser is just another way to take off the bone. So we do the exact same thing, just with a kerosene, the old-fashioned way, just not using a laser. So it's very similar. And I do laminoforaminotomies from the back, and I can also decompress that nerve from the back, but it's not going to address the joint right up here. You can't get to this joint because the nerve is in the way. Does that explain it at all?
Yeah, so after you do that, does it speed up the process of that degeneration of that joint again, or do you have a lot of time before, say, it kind of spurs in there again?
Yeah, that's a great question. So I was just reading and preparing for this. I was actually shocked by that. So Herkowitz, who was a very well thought of a spine surgeon and had a very untimely death, but he did a very good study where he looked at adjacent segment disease after laminoforaminotomies, and it was virtually the same as doing an ACDF, which was just virtually shocking, because you think by going in and doing this much less invasive surgery, you just take down a little bit of the bone in the back and do a nice little decompression, you'd think, oh, you know, that's not going to lead to adjacent segment diseases as much as going in and taking that whole disc space out. But it actually showed that it had the same statistical rates. So that was kind of interesting to read. So that's a good question.
All right. Any more questions? If not, Dr. Geisinger, if you want to just run through the 6 questions real quickly.
Sure. And I apologize. I see 5 of them. I must have accidentally moved or deleted one of them. But question 1, anterior cervical decompression and fusion can be used to treat the following: deformity, instability, radiculopathy, myelopathy, or E, all of the above.
E.
And you want me to say the answer or just keep going through them?
Yeah, I might want to do the answer, then I can write it down so I can get ready.
Okay.
I can put together the quiz.
Yeah, so E.
Yep.
Cervical disc replacement can be used to treat the following: radiculopathy, myelopathy, or all of the above. C, all of the above. True or false? The goal of cervical disc replacement is to retain motion and not to recreate motion. And that is true. You want to retain the motion. You're not trying to take a level that's not moving and make it move again. True or false? The best candidate for a cervical disc replacement is a young person with 1-level disease. And that is true. And then 6, actually 5, studies have not shown a conclusive difference between ACDF and disc replacement in terms of adjacent segment disease and reoperation. And that is true. There has not been shown to be a difference. And I apologize for that other question. I don't know where the slide went.
No, that's right. We can come up with another one. Well, Dr. Geisinger, again, thank you for your time. Last chance. Anybody? Last questions or comments for Dr. Geisinger? If not, again, thank you, and everybody. I'll make sure they have your contact information if they don't have it already. If they have any follow-up questions or they need any more information from you.
Yep, that'd be great. Well, thanks so much for having me, guys.
Appreciate you.
Thanks, Doc.